We talk about sudden death, and when we look at the issue of sudden death, there are about 100,000 sudden deaths in the United Kingdom each year. They normally affect people in their 60s and 70s. Deaths in young people are relatively rare, about 160 deaths per annum, so that looks quite small compared to 100,000. But if we give consideration to the age of these individuals, they lose thousands of life years. So per annum, I think there are 5,000 life years lost. And when I say it like that, it sounds like a bit of an epidemic. So one of the issues is that they're not picked up. They sometimes go to see physicians or school teachers, school nurses, and their symptoms aren't always picked up. So what we're going to do today is cover 4 conditions quite rapidly and see what we make of this. Of course, the cardiologists in the audience, particularly the consultant cardiologists, may find this all too easy, but please bear with me. We've got a very, very broad type of audience, and there are some people that may be a bit slower than you. I suggest that you don't get involved in the interactive part unless people are really stuck, okay? So let's kick off. First patient is a 22-year-old Caucasian male who presented with chest tightness and breathlessness whilst training for a 5-kilometer race. He was asymptomatic otherwise. There was no history of diabetes or high blood pressure, and he'd never smoked. So no acquired risk factors for atherosclerosis. His father died young from a cardiac problem. His mother and young brother, aged 18, were well. Physical examination was normal. His blood pressure for a young man was normal. Hemoglobin, normal. Urea, normal. Blood sugar, normal. Total cholesterol within normal range. And this is his 12-lead ECG. Everyone seen it? Seen enough of it? Right, so question number 1. Would you interpret this ECG as normal, A, B, abnormal, or within normal limits for a runner? So let's have normal. No one. Abnormal. A few people. Normal limits for a runner. No one. So quite a good audience. So everyone says this abnormal, and it surely is. You've already heard, some people have done my work for me, that the athlete's ECG reflects 2 things. It reflects vagotonia and increased chamber size, sinus bradycardia, sinus arrhythmia, first-degree AV block, ST elevation, and tall T waves are common, as are voltage criterion for left ventricular hypertrophy, incomplete right bundle branch block, and voltage criterion for atrial enlargement. So this is a typical athlete's ECG, showing the sinus bradycardia, showing the large QRS complexes in isolation. What you don't see here, in association with the voltage criterion for left ventricular hypertrophy, is the ST segment shift downwards, or T-wave inversion, which should make you think of pathology. So this is a normal ECG. When we see T-wave inversions, they may be normal in 2 situations. They may be normal in young children aged under 16, or they may be normal in black athletes, but even in those individuals, they're confined to leads V1 to V4. However, otherwise, whenever we see T-wave inversion in an athlete, we should think of cardiomyopathy or anabolic drug abuse, but I would like to exercise caution here because we don't know much about the veteran athlete. So I don't know what someone who's been running marathons for 40 years, what their ECG should look like, and T-wave inversion may be a normal variant in that group. So knowing all this, what investigation would you request next? Bearing in mind you've seen his ECG. Who's going for an exercise test? Who's going for a coronary calcium score? Echo. Dobutamine stress echo. 24-hour Holter. So everyone went for an echo, and we did an echo. These are real-life cases, by the way. So his echocardiogram, for those of you that don't do echocardiography, this is the parasternal long-axis view. This is showing you the left ventricle. This is the left atrium. This is the mitral valve apparatus. And what I want you to appreciate is that he's got a very, very thickened interventricular septum compared with his posterior wall. And this is pathognomonic, this particular echocardiogram, of hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy is a genetic condition inherited as an autosomal dominant trait that is characterized by unexplained left ventricular hypertrophy and a predilection to fatal arrhythmias. It's the commonest cause of sudden death in young athletes worldwide. It's not as rare as you'd have thought. The prevalence is 1 in 500. It's a very heterogeneous condition, both genetically, clinically, and as far as its natural history goes. Now, most of you would think that someone who's got a hypertrophied ventricle like this myocardial fibrosis, small vessel disease, and impaired myocardial relaxation is not going to be able to be a top sportsman. And that is true in the vast majority. The vast majority of people with hypertrophic cardiomyopathy do have some symptoms in the form of chest tightness, breathlessness, palpitation, or syncope. But as I said, there are two words that we don't use for this condition, and one is always, and the other is never, because it's a very heterogeneous condition. And some people are able to compete at very high level, including at national level, particularly in sporting disciplines that involve a start-stop nature, such as football, basketball, and baseball. They're not so good at sustained increases in cardiac output, such as the Tour de France, such as marathon running, which is why you hardly ever hear of a Tour de France guy dying from hypertrophic cardiomyopathy. They're actually selected out of this sort of discipline. This is a slightly complicated slide, but what it shows the cardiologists in the audience is that you're probably going to get an athlete at the prime of their career. That is, between the age of 12 and 35. And when you get this athlete, you may hear about them either because they've suddenly died and they're on the PM slab and you've heard about this death and you're looking at their family. At this stage, they may have severe LVH with only mild symptoms. They may have no symptoms, but just mild LVH because they've been picked up at a pre-participation screening. But importantly, an ugly ECG may be the only manifestation of this condition in the context of a family history of cardiomyopathy. So if you see a young person who's got an ugly-looking ECG, whose father died, but whose echocardiogram is completely normal, or his MRI is completely normal, you don't pat them on the back and say this is all athletic training. You probably pat them on the back because there's not enough to say they've got a cardiomyopathy, but you go and you follow them up and see them again in a year's time. As far as the ECG in hypertrophic cardiomyopathy goes, there are no specific ECG markers. The two things you need to take away from this slide is that the ECG is abnormal in around 95% of cases of hypertrophic cardiomyopathy. That's lesson number one. Lesson number two is that large QRS complexes are common, but hardly ever in isolation. You normally see accompanying ST segment depression or T-wave inversions in these people. So an athlete's ECG, this is an individual he saw three cardiologists, by the way, an ultra-distance runner, so not a marathon run. They run quite slowly, but they run for a long time. And we were asked whether this was normal or abnormal. Now, people were seduced by the fact that he was an ultra-endurance runner, and they thought this may be normal for him. But is this normal or abnormal? Hands up for abnormal. Okay, so the things that bothered me were that he's got ST segment depression in the inferior leads and T-wave inversion in the lateral leads, never to be considered as normal in a Caucasian athlete. And he was a soldier. This guy's a top soldier who was doing well in his bleep test, but his doctor heard a murmur. And this guy has got extreme left axis deviation, but not just in isolation. He's got other abnormalities, pathological Q waves, which are not normal, as well as those odd-looking R waves in V1 and V2. So in a nutshell, I can't teach you all about hypertrophic cardiomyopathy, but if you see a patient with hypertrophic cardiomyopathy, chest pain and breathlessness are treated by lifestyle. You tell them not to exercise too hard or not to be involved in competitive sport. Beta blockers and calcium channel blockers are the mainstay of therapy for symptoms. Amiodarone, I say through gritted teeth, is the drug of choice for atrial fibrillation, or as PAF. Survivor of sudden cardiac death gets an ICD. We risk stratify these people with various tests, and I'm not going to go into that into detail, but the important thing to remember, this is a genetic condition, and we must offer first-degree relatives an assessment, because by doing that, you may prevent someone else in the family from dying. Case scenario 2, 26-year-old male was referred with intermittent palpitation, which he described as a missed beat followed by a thump in the chest. No history of excess alcohol or caffeine intake. He competed in high-level amateur cycling and noticed that the symptoms were worse immediately after exercise. There was no family history of note. His appetite was good. His weight was stable. Physical examination revealed an irregular pulse, blood pressure normal, auscultation of the precordium normal, urea and electrolytes normal. Now, these are real-life cases, okay? That's his ECG. I've modified the ECGs a little bit. Everyone seen it? And this is his rhythm strip. Seen it? would you interpret this ECG as normal, abnormal, or within normal limits for a cyclist? Normal. Abnormal. Normal for a cyclist. Everyone here has got the message that T-wave inversion in a grown-up person should make you think abnormal. And he had that ectopy, of course, conducting with left bundle branch bulk morphology, suggesting it's coming from the right ventricle. So abnormal. And just for those of you that look after athletes, T-wave inversions may be a juvenile pattern, and this came up early on, and I know that I've got Graham Stewart in the audience, who's going to be speaking to us later, a pediatric cardiologist and an electrophysiologist. But if we look at young people aged under 14, then the prevalence of T-wave inversion from V1 going up to V4 is nearly 10%. Once they get to about 14, that drops to 1.4%. And the persistence of T-wave inversion beyond the age of 16, that is, if it goes beyond V2, we start to get a little bit concerned that there may be something going on. But up to 16, we do see it. So an echocardiogram was requested in this case, which showed mild biventricular enlargement with preserved ventricular function and normal valves. There was no evidence of an intracardiac shunt. Are you surprised by the enlarged ventricles? Well, if there's not another thing that you need to take away, 50% of athletes have either an enlarged left ventricle or an enlarged right ventricle. So we don't get excited when the ventricles are enlarged. We get excited when the ventricles are enlarged and there are regional wall motion abnormalities or impaired systolic or diastolic function. So what would you do here? What's your next test? Remember, do it as a clinician. He came in saying that he got thumps in his chest during exercise or after exercise. So what's your next test? Everyone, who's going for a 24-hour tape? Who's going for an exercise test? Signal average ECG, cardiac MRI, thyroid function test. I think the unanimous decision is exercise test. This is what happened during an exercise test. So he's got, would you agree, a broad complex tachycardia, which seems to be coming from the right ventricular outflow tract. There's an inferior axis, but it's going very, very fast. He has got an abnormal resting ECG as well. So, what diagnosis would you be suspicious of here? Who's going for A? Who's going for B? Who's going for C? A couple have said C, could be right. Certainly the ECG that you saw was right ventricular outflow tract tachycardia. Who's going for ARVC? Most people. Who's going for premature coronary artery disease? And I would agree that ARVC is the correct answer, not because of the VT, but because of this resting ECG. That resting ECG showing you T-wave inversions in V1, V2, V3, V4, you don't normally see that in typical RVOT VT. This ECG suggests pathology, and you would have to be hunting here for ARVC. Again, ARVC, another hereditary cardiomyopathy that's characterized by fibrofatty replacement of the right ventricle and also the left ventricle at later stages. It's a desmosomal protein mutation. The theory is that the myocytes are attached together by desmosomes. These desmosomes are defective, so during exercise, the myocytes may detach, causing VT. People who recover from that may go on to get a myocarditis and subsequent scar, which is another substrate for ongoing VT and heart failure. And this is the commonest cause of sudden death in the Italian athlete group. Now, I don't know whether that's due to a genetic cluster or the fact that their screening program selects out HCM, which is a far less common condition. This is a very difficult condition to diagnose. It's got 4 phases. We don't understand the natural history completely. The early concealed phase, that worries all cardiologists because all you see here maybe is an abnormal ECG and nothing more than that. You may get the overt electrical disorder where you get lots of ectopy and maybe runs of VT. This bit gets easy, progression of myocardial disease. Sadly, most athletes drop dead during stages 1 and 2, don't quite get to stage 3. And then, of course, in the advanced stages, the heart starts to look like the heart of a dilated cardiomyopathy. The diagnosis, I haven't got time to go through it. There's a task force criterion which bases the diagnosis on the ECG, the echocardiogram, the MRI, the results of a signal average ECG, and family history. You've got a histological specimen here, but of course in the UK we don't do biopsies because to do a biopsy, you need a transmural biopsy of the free wall. I think you'd have to phone up the Medical Defence Union before you did something like that. So we rely on imaging here. But for those of you that don't look after athletes, this ECG is an alarm bell ECG. T-wave inversions in an adult athlete, white athlete going beyond V2 with ectopy coming from the right ventricle. Not a good ECG. It gets very easy if you see this, but as I said, sadly, we rarely see this, a very dilated and hypocontractile right ventricle compared to the left ventricle. If you see this, of course, bingo, you've got your diagnosis, assuming that you've excluded an ASD and anything else that may be causing pulmonary hypertension. And again, the management here, we tell athletes not to compete. It doesn't go down very well. Beta blockers for symptoms of arrhythmia. Anyone who's died before, we don't let them die again. We put an ICD in. And risk stratification involves high-risk markers. High-risk markers include VT with hemodynamic compromise, syncope without warning, RV dysfunction, and left ventricular involvement. Again, I go back to the family. These things are genetic. You've got to offer genetic screening. I'm sorry I'm belting through this. I've got a few more minutes to go through. Two more. 30-year-old woman presents with several episodes of transient dizziness and near syncope over a 12-hour period. She'd been unwell a few days previously with a lower respiratory tract infection and hadn't been eating much. She visited her GP 48 hours previously, who prescribed clarithromycin. She fainted twice in her life, once in a hot nightclub, and once a few days later. I've only fainted once in my life in the dental surgery. It was my wife's dental surgery. It was shortly after she gave me the bill, but not before that. Her sister had epilepsy. She was allergic to penicillin. Physical examination was normal, blood pressure normal, lying and standing, so nothing exciting there, except for this worrying-sounding syncope that started with the lower respiratory tract infection. And this is the ECG. Everyone seen it? I'm going a bit fast for some of the students, I guess, but I'm going to have to. So, most of you will agree that this is an abnormal ECG. So, what investigation would you request? We'll come back to the ECG in a minute. Not been eating much, respiratory tract infection, started on some pills by the GP, and now she's fainted. Anyone? So who's going for A? Who's going for B? Who's going for C? Who's going for D and E? Some going for D, some going for E. I must say that being a clinician, I'd wanted to know the electrolytes and the magnesium first, bearing in mind how she's presented. She's presented to us with a faint, and with that ECG here, with a long QT, quite a long QT in fact, and notched T waves, I'd have been concerned about maybe an electrolyte disturbance or hypomagnesemia. Of course, she's on a tablet that may be causing this. And shortly after admission, she did everyone a favor by having another syncopal episode that looked a little bit like this. It's like a sinusoidal wave. This is polymorphic VT, also sometimes known as torsade de pointe. Now, this is for the SPRs. What's the immediate management here? She's come back out of it, by the way, and says, I'm fine now. What do you do next? Who's going for A? Who's going for B? Who's going for C? Who's going for D? Sounds like a part 2 question, doesn't it? Stop the clarithromycin, always be safe, stop the drug that's causing it, and load this patient with magnesium, even if the serum magnesium is normal. That's the first two things you do. And of course, DC cardioversion doesn't come into it because she's actually in sinus rhythm. So that's what we do, correct? And luckily, Elijah's done me a massive favor, so I can speed through this. We talk about the congenital long QT syndrome. But in terms of sport, there are situations where sport can take its toll on an individual with an ion channelopathy. Deaths are much more common in swimming, particularly females. You hear of a good swimmer that went down into the cold water and didn't surface back up. That should always make you think maybe a congenital long QT death. Now, anyone who's waiting in the tunnel to come out to play at White Hart Lane is petrified. They have to be if they're playing at White Hart, but against us at White Hart Lane. And that's a cause of intense emotion, which may cause trouble. Loud stimuli can cause trouble. Fear, and of course, performance-enhancing drugs. All of these things can take their toll on an individual who's got a sodium or potassium ion channel abnormality. There are some genotype-phenotype correlations. People with long QT1 are more likely to die during the adrenergic stresses of exercise. People with long QT2 are more prone to die during loud auditory stimuli or intense emotion, or even with drugs. And sadly, people with long QT3 often die during resting conditions during sleep. But there is an overlap here, so it's not a line in the sand where this holds true for everything. The diagnosis of long QT, again, Elijah, help me. You shouldn't just rely on a long squiggle on the ECG. That's a bit dangerous in an athlete. So it's a long QT plus unheralded syncope, either torsade de pointe, identification of a long QT in other first-degree relatives, or a family history of sudden arrhythmic death syndrome. In athletes, I would be very confident that someone's got long QT. If the QT is 500 or more, there are notched T waves, and there's paradoxical prolongation of the QT interval. Risk factors, of course, aborted sudden cardiac death, people who are blacking out without warning, torsade de pointe, a QT of more than 500. Males normally die in the prepubertal stage. Women normally die during adolescence and in the early adulthood stage. Long QT genotype 2 appears to have the worst outlook. Recommendations, we're told to abstain from sport because sport isn't just an adrenergic surge in terms of physical activity, also fear. Gentle recreational sports permitted. Avoid drugs that cause long QT. Beta blockers in all those with congenital long QT. ICD for aborted sudden cardiac death, or those people that are still symptomatic despite beta blockers. And final case quickly, 42, single bout of loss of consciousness shortly after eating his lunch. There was no history of preceding chest tightness, palpitation, dizziness, or nausea. He'd been unwell, again, with a lower respiratory tract infection, and had several febrile episodes. Wasn't taking any medications. There was one episode of syncope after a hot bath just after a year ago. No family history, normal examination. What investigation would you do next? You're clinicians, most of you. Come with a syncopal episode. He's got to have one test. What is it? Got to have an ECG. The transient loss of consciousness guidelines say he's got to have an ECG. That's his ECG. Okay. Everyone seen it? So, what's the diagnosis? Brugada syndrome. Okay, so what we've got here, I think Elijah's already shown this for me. We've got an RSR pattern with a coved ST segment elevation in V1 and V2. And again, you've seen all this. I'm not going to go through it anymore. What's the management? Syncope without warning, ugly-looking ECG during a respiratory tract infection when he's febrile. Anyone? No treatment, flecainide, beta blocker, lifestyle, or ICD. Who's going for an ICD? I think when you've got a type 1 Brugada ECG pattern and you've got syncope, that's, in this case, probably been precipitated by his febrile illness, because once he cooled off, his ECG became completely normal. He ended up going to the cath lab for a query MI. It was a day that I was on call, although I kept saying this is Brugada. But anyway, so we know about Brugada, so I'm not going to go into this. They normally die in their sleep, and the treatment for high-risk individuals is an ICD. But this is the important thing I want you to take away, is the advice we give people who may be low risk, i.e. those people who don't get the Brugada ECG unless they're provoked with agmaline or hyperpyrexia. We ask them to avoid class 1A, 1C, and class 3 antiarrhythmic agents, to avoid tricyclics and neuroleptic agents. Young kids especially avoid amphetamine-based drugs. Treat fevers above 38, so we tell them not to immerse themselves in hot baths for prolonged periods and not to stick around in saunas for prolonged periods. And we think that vagotonia may have something to do with it, so we advise them usually to sleep on a light stomach, so 2 hours before they go to sleep, no food. So, take-home messages. Sinister cardiac conditions frequently present with common symptoms. Early recognition facilitates appropriate therapy and saves lives. You've just seen here a 12-lead ECG is very simple and a useful investigation in young patients with cardiac symptoms. Thank you.